Now I invite Dr. Satish Kumar, who is going to present a case on LDLT graft dysfunction. After that, we will go for Professor Heaton's talk.
Thank you, sir.
Dr. Satish is a consultant in our unit. He newly appointed, and he is going to talk about very common scenario and also how to manage. Thank you.
Thank you, sir. And good evening and good afternoon, one and all. As discussed, I am here to present a case patient, a gentleman who underwent living donor liver transplant in our unit recently, who had a early allograft dysfunction. So this gentleman is a 45-year-old male who had a HPV-related DCLD with a CTP score of C and MEL 26. He was decompensated with jaundice, ascites, and left hydrothorax. For which he underwent recurrent thoracentesis, and he had a recent history of SBE. He was a 75 kg male with a BMI of 26 and above a Karnofsky's performance score of 70 and liver frailty index of 4.3, which comes in the category of pre-frail. And as I said, he had a recent history of infection for which he needed an ICU admission and was on vasopressor support for 2 days. And after control of infection, his immediate preoperative cultures were negative. And so in that window, we planned for a transplant for him. His wife came forward to donate. She was a 44-year-old female with no known comorbidities, and but she had a higher BMI, slightly 30.2. Her LA was +5 and an MR fat fraction of 9.9%. But her MR elastography was normal, it's 2.5 kilopascals. So we planned for a right lobe graft without MHV, and we had a calculated remnant of about 40%. So intraoperatively, we managed to get a GRWR of about 0.98 for a graft weight of 745 grams. And we planned for a single outflow. She had two V5s and one V8 in the anterior sector, which was reconstructed with 8 mm PTFE, and it was done as a single outflow. So other than that, it's a standard implantation for an LDLT. This was the graft after the benching, showing the PTFE, 8 mm PTFE joined to the two V5s, which were we need to put a patch to connect it with a V8 and joined with the RHV as a single outflow. So intraoperatively, the portal pressures before implantation was 16 and post reperfusion was around 13. Since it was less than 15, we didn't do any inflow modulation intraoperatively. The cold ischemia time was about 104 minutes and a warm ischemia of 38 minutes. He didn't have any significant reperfusion injury. He had a peak lactate of about 3.1 and an end lactate of 2.5. He had a 6 units PRBC transfusion intraoperatively. Postoperatively, on day 1, he was off inotrope support overnight, and his Dopplers were normal on the next day morning, and hence he was extubated. And he was started on orals from day 2, and gradually from day 4, he developed cholestasis. We did a CT screening which showed normal vasculature, and there was no any obvious significant intra-abdominal collections. And day 5 had an increasing cholestasis with transaminitis, and platelets started to drop with the INR rise. On day 6, we noticed a slow mentation with slurring of speech. So we thought this could be due to attack-related toxicity, and then hence we switched over to cyclosporine from day 7. But still on day 7, his enzymes were still on the increasing trends with the lower platelet and coagulopathy, which was corrected based on viscoelastographic findings. On day 9, graph started to stabilize with drains were static, but still the graph dysfunction was there. And slowly over day 10, 11, 12, and 13, his graph function gradually improved. Drains started to come down and platelets picked up. With appropriate antibiotic cover and appropriate fluid management and enteral support and physiotherapy, we managed to bring out the patient from this dysfunction, and he was discharged with a stable graph function on POD 14. So this was the trends in his labs. We can see the bilirubin levels, which started to rise from day 4 onwards. Peak was around 910, and day 7, the bilirubin was around 15. On the same day, he had a platelets of 20,000 and iron of 1.1, and drain output was also maximum on that day of 1.4 liters. And slowly, as the graph stabilized and regenerated, platelets started to improve, and bilirubin started to show a downward trend, and INR also started to improve. And on follow-up, post 1 month now, he is doing well. His current bilirubin is 2, AST is 23, creatinine 0.7, and his recent cyclosporine level is 160. And donor is also doing good. She had a peak bilirubin of 3.9 in the perioperative period, and current bilirubin is 0.9. She had a hospital stay of 6 days, and we do a protocol 1 month CT for all donors, so which showed a good remnant regeneration of around 88%, and she's doing well. So this patient had a early graft dysfunction. The preoperative risk factors were high MEL score. He was also frail with a history of recent sepsis and ICU admission. On top of it, he also had a marginal donor with a slightly higher age, 45 years, with the 30 BMI and steatotic or borderline steatotic graft, with complicating factors of low platelets and also a neurological injury in the immediate perioperative period. Probably it is track related, because once we switched to cyclosporine, his mentation and neurological symptoms improved. But the positive aspect for this patient was he had a preserved renal function. There were no technical issues, and there was no sepsis. Hence, he was about, we were able to discharge him on the second week, 14th day, at the end of second week. Thank you.
Thank you, Satish, for good case. We will go for any questions here for LDLT graft dysfunction. Yeah, Srini, thanks. There are some questions in the chat box. I can see Sanjay Govil is asking, it's a great talk. Just you enumerated everything.
Yeah.
Except portal hyperperfusion. He wanted to know how it is causing early graft dysfunction and how to manage.
Thanks, Sanjay. Can you hear me?
Yeah.
Okay. I think that's an important topic, but I felt that already it is becoming too long. So I think in the living donor setting, hypoperfusion is a problem if you have large collaterals, and especially because a small graft becomes stiff. These collaterals can actually steal blood away from the liver. So the key is to identify these collaterals preoperatively on the scans, and then try and close them down intraoperatively. I think this is not such a big problem if it's a good quality graft and a good GRWR graft, because the portal system is decompressed sufficiently that these shunts will close down. But if it's a marginal graft or a small graft and the graft becomes stiff, the shunts will not close. So we need to try and close them, whether it's we usually do a ligation of the coronary vein, or we tie the left renal vein to shut down any splenorenal collaterals that might be present for this patient. I think the second question is from Dr. Ravi Kumar. Is early graft failure criteria for pediatric the same? So that's an interesting question. I didn't actually think of that. It's very uncommon that children actually develop early allograft dysfunction, because especially in the LDLT setting, because it's usually a good quality graft and its volume is good. But it can happen, and we've had patients who, older children or adolescent boys who get graft is slightly smaller, and then they have this persistent cholestasis, and shunts open up. There is portal steal. So yeah, this can happen. Again, basically, what we need to see is whether this child is going along a normal expected clinical pathway, or are they struggling? And if they are struggling, then they're cholestatic, then they need to be managed as early allograft dysfunction, just as we manage in adults. And I think the last question is Dr. Raghavendra is asking, what's the role of plasmapheresis plasma exchange? Like I said, the role is not clear. The literature is not definite. I mentioned about our own publication last year, which showed that actually doesn't benefit and increases septic complications. I think the key is patient selection. If you have an already inflamed patient with SIRS and we put them on an extracorporeal circuit, it's actually going to worsen things. We've used it selectively for patients who have become very cholestatic. Bilirubin goes more than 20, or patient is also having a kidney injury, then we use it. I don't know if Dr. Selva would like to take this question. He's our chief intensivist, so he does all the decision making in the ICU. We just listen to him.
Thank you, Rashmi. So this was about the plasma exchange. Actually, we are not really aggressively pushing for plasma exchanges in the post of graft dysfunctions. I guess when we had cholestasis with some renal failure, maybe encephalopathies, those patients we have tried doing plasma exchanges, but except in specific situations, there are a lot of issues in terms of immunosuppression and the fact that the exacerbation of sepsis and all that. So generally, I don't think it's a very viable option except in specific situations. Actually, I wanted to ask you a question. So we have multitude of differentials for a post-op graft dysfunction in terms of, say, technical issues, say something like a small for size or a pressure injury or a rejection, or systemic sepsis. So I know these are all multidimensional problems, but can we simplify them and say put in specific PODs what are the most possible things? Say, for example, first 2 days or first 3 days. This is the first thing we do with that, and maybe after a week, something becomes the first week, then the other one, something like that. Can we have a simplified?
I think it all depends on how the patient is preoperatively. For me, sepsis is always at the back of my mind. I think technical complications. I think now most centers are experienced enough that you don't have this catastrophic vascular complications and all. You might have some problems with outflow. Maybe the anterior sector gets thrombosed, or there might be some cholestasis because your bile ducts you sutured some bile duct off. But I think sepsis is always in the back of my mind, and especially patients who are sick, who have come from the ICU or who had a recent ICU admission. For them we need to first rule out any source of sepsis. So I would always do a scan. We do a Doppler anyway to make sure the vascularity is okay, but we do a plain CT to make sure there are no collections, there's no hematoma. Even a small hematoma can get infected by the end of the first week, and then that can actually drive the whole process. So I think it's important to actually look at the patient, like I said, in his entirety, look at imaging findings, look at the blood tests, and then make a decision. I think if you're talking about time frames of various causes, I would say that technical complications should usually present early on, or if the surgery has gone, it's been a difficult operation, then the patient should have problems from early on, actually. What we usually see is patients do okay for the first 2 to 3 days, and then towards the second half of first week, they start becoming cholestatic, like we saw in this example. And that, I think, is because of the effects of graft regeneration, excessive regeneration, or is because of some sepsis which has got flared up. So I think these are things that we need to look at. I think rejection per se is not that common a cause of early allograft dysfunction in these patients, in the sick patients. I think there's one question here.
One more question.
Yeah, Dr. Gautam Krishna said, is there any particular etiology associated with higher EAD, or should we? I mean, I don't think there's any particular etiology, but obviously patients with ACLF will have a higher chance of developing early allograft dysfunction because of all the previously discussed factors. I think alcoholic liver disease patients, because they are always frail, they're nutritionally depleted, and they might present with an ACLF-like picture. They are more likely to have early allograft dysfunction as compared to hepatitis B or hepatitis C patients. I mean, that's my opinion. I think I'm not sure if I'm entirely right. I think if that's it, we should go to the long awaited Nigel Eaton's talk.
Yeah. Thank you, Srini.